I am a professor at UCLA in Los Angeles, California. I need pictures of the beach. I will bring those tomorrow to show you what that looks like. Anyway, I'm very happy to be here. I'm going to talk a little bit about early intervention programs that we have been doing in the United States, and particularly around teaching parents strategies for working with their young children with autism. So right now, the only interventions that we know are effective for children with autism are behavioral or educational. So in other words, medications have not been found to be effective without behavioral and educational interventions. But we know that kids can make a lot of progress if they get early intervention. So the little baby at the top picture is a little boy that came in who was very, very delayed. So at 2 years of age, he was functioning like, an 8-month-old. He would not have been a baby we would predict would go on to have a good outcome because he was so delayed. But in fact, with early intervention, at age 7, he came up to me in a talk like this and said, "Hi, Dr. Казари," and started to talk. Was fully included in a general education classroom, was doing very, very well. So not only did the early intervention help this little guy, but so did his mother, who never let him go, who just worked tirelessly for helping him. So we can't always predict from when we see a little one to where they're going to be. So early intervention matters, and some of the children have very positive outcomes. All children make progress. But sometimes, the progress is less good than what we would like it to be. So there are several things to consider. So we know that behavioral interventions are effective. We know that we need to focus on the core deficits. So what are those deficits that we're working on in the children? They're social issues, they're communication issues, and they're the repetitive behaviors. So, for example, we want to spend more time on these behaviors than we would on, say, motor skills for most kids. Some kids will need that kind of attention, but the majority, we need to really focus in on social communication issues. There are lots of different kinds of behavioral interventions, and it's clear that one particular treatment is not more effective than another because we haven't tested them against each other. But we do need to focus on those core deficits. And when we do that, we get changes in cognitive skills, in language skills, social skills, and families are less stressed and they're happier when their children are making progress, right? Are you with me? Yes? Yes, okay. The problem is that early interventions are very expensive to deliver. So what we know is that they need to be at kind of a high dose. So about 20 hours a week is what's recommended. And the structure needs to be one-on-one a lot of the time. And you need to have highly trained professionals. So those kinds of things are very expensive. However, we also know that we can get very, very good results with far less dose, far fewer hours, and less structure. And we also know that parents and teachers can get similar and even better results sometimes than therapists. So it's important to know that we don't need to have really expensive models to make change. Okay, so the problem is that not all of our interventions that have been developed actually focus on those core deficits. So sometimes they only focus on behaviors, like behavioral problems. And they may not teach the kinds of skills that actually can get maintained and generalized, right? Because they're not focusing on those core deficits. Most studies on behavioral treatments have focused on IQ. Do you know what IQ is? Right? So an IQ is not a core deficit. So we have many children who can't speak but have normal intelligence. Because if you test them with a nonverbal IQ test, they test in the normal range. So just because you have autism doesn't mean that you have intellectual disability. So that's important. So that's not our most important outcome. Our most important outcome has to do with their ability to relate to other people, to actually be able to use communication. You know, we want them to have spoken language, but if they can't speak, sometimes we just want them to be able to communicate, and they can do that with other means. All right, so IQ is not a core deficit, should not be our main outcome. So let me show you why different behavioral interventions are more or less successful. And the reason I'm telling you this is because, well, you may start out with one therapy, and if you don't see progress, you need to change it up to include other aspects, other kinds of behavioral therapies. So I'm going to show you a video of a very common ABA approach, which is called discrete trial training. It's very one-on-one, it's very repetitive, it works with a lot of children, but it doesn't work very well for some kinds of goals. So if you're trying to improve, say, matching skills, like if I say to find the ball, can you find the ball? That works fairly well. And you're going to see a matching program with this little girl. What you see is the same kind of instruction, and the therapist is mixing up where the placement of the object is to see if the child understands what that object is. Very simple, very repetitive. I would argue with this little girl, she might be smarter than that, and that's a boring task. But for children to start out, that sometimes is a very effective approach. It's called discrete trial training. Do you have that here? Yes? Maybe? Okay. Here is teaching a child a play activity. Same method.
Okay, let's work for more.
So with this little guy, this is way too easy for him. And so he's more excited about that toy he gets and can play with it. So she's giving something to do it, then you get reinforced or get positive praise for doing it. And then he plays with the toy, which is probably at a higher level. So this is not a very good approach for teaching play, right? So kids in Russia, like they do everywhere in the world, play. And when they're little kids, they need to learn to play with toys and to play with other people. And this approach does not have a very good record for teaching play. So there are other behavioral methods for teaching play. And we have done this with a method that we developed called Jasper, which is about joint attention, symbolic play, engagement, and regulation. I'm going to talk more about it tomorrow.
All right.
Yep. You're showing it already. The intervention is behavioral and developmental, and the goal is to really increase engagement with the person and better play skills. So you're going to see a mother and a 21-month-old, the same little boy I showed you in assessment earlier today. This is with his mother playing before we started intervention. So now you can show the top of it.
All right. That was hard, eh?
Okay, well, if you could see his face, which you can't, he's not paying any attention to his mother. So mom is being responsive. She's talking to him, she's trying to play with him, but she doesn't have strategies to help her sort of break through that object focus the child has. Very simple activity, and she's kind of sitting behind him, and he's very object focused. So what we want to change is the interaction. We want them to be communicating together. So I'm going to show you what they look like after 20 sessions. So twice a week for 10 weeks. Short sessions, like half an hour. All right? So here's the next video. So I think in terms of early interventions, we really need to understand what those active ingredients are. What do we need to do with this child and this parent in front of us? What kind of dose does this child need? What kinds of methods and strategies are going to bring about that change? Where should intervention take place? You know, home or school or wherever. And then who's best to deliver the intervention? So sometimes it's always the parent, but sometimes the parent needs additional support from therapists, professionals. Okay. And then what kinds of skills need to be taught? Those are all of the active ingredients we need to ask ourselves for a particular child. So in the United States, we know that recommended practice for early intervention is parent involvement, that parents can actually increase the dose of intervention. So if a professional works with a child, then they can train the parent so the parent can do the same thing all through the day or use some of the strategies all through the day. A lot of times in the United States, children also attend preschool programs. So it's also important to train teachers so that they can increase the dose of intervention. Okay. Are we on the next slide? Okay. So we've done research studies at UCLA where we've worked with parents and their children. We just finished one study of 86 toddlers, 2 to 3-year-olds, and another study with 110 2 to 5-year-old children done in the home for a short period of time, about 3 months and about 20 to 24 sessions. What we know is that when we do this, we can increase parent-child engagement, how long they're engaged with each other. So if you press the little button, you'll see the little arrow come up. Does it? Aha. So that we know that we can increase engagement and that engagement will last. If we stop treatment, 3 months later we come back and the parent they're still showing that level of engagement. So you train the parents, they can continue the intervention, and it works. Okay, we also know that we can change what teachers do. So, no, this is another study, I'm sorry. This is a study of parents who got Jasper hands-on treatment versus parents who we just told them what to do. So we didn't work with the child, we just said to parents, try these activities and see if you can do them. And you can see that the top line, the next slide. So the black line, the top line, are parents who got hands-on intervention for 3 months. And the parents on the dotted line are parents who got lots of intervention but no hands-on treatment. We just told them what they could try with their children. So parents need that added support with their child, individualized to their child, and then they can make great gains. Okay? Okay, so when I talk about core deficits with young children, what we're talking about and what you want to focus on are, you have to keep pressing the button, sorry.
Okay, sorry.
Keep pressing to the picture. Okay, stop. Shared attention and affect, you want to focus on that. See, next one. Joint attention. And do you understand what joint attention is? Do people know what this is? No, maybe. Let's talk about it. So an example is if you were in the park with your child and an airplane is flying overhead, the child might point to the airplane and look back at you and back to the airplane and back at you as if to say, oh, wow, do you see what I see? Right? They don't want you to get the airplane. They just want to point it out to you. And that's different from the child who knows that the cookies or the crackers are in the cupboard, and they point to the cupboard because they want the cookies. That's a different kind of point. That's what we call a requesting point. They want you to get it, you know, and they're going to be mad if you don't give it to them, right? So this pointing to the airplane and sharing with you is something our kids with autism don't do very much of. But it's really an important skill because that skill predicts to spoken language. And we know this from a lot of studies with children with autism, children with typical development as well. So that gesturing, that sharing of an experience is really important, and that's one of the things that we want to teach. Okay, so now let's go back to wherever we were. So the other core deficits are social play with other children and then conversation. So these are things that we really want to focus on in our interventions. Okay, let's go to the next one. So we know that we can change these kinds of core deficits in our interventions, that if we directly target play, joint attention, imitation, we can improve those areas. And we know that these interventions are pretty common components now of behavioral interventions with young children, so under the age of about 5. Go to the next slide. And these are some data from studies that we've done where you can see, you can put the little circles there, where you can see that the children are increasing in joint attention and play, but the most important thing is that increasing those skills matters to spoken language. So when we follow them up a year later, kids who are getting these very targeted treatments on joint attention and play do better in language test scores than children who get only ABA. And you have to realize all of these children are getting 30 hours a week of ABA in a school program at 2 years of age. Can you believe it? So that's in the United States. So imagine what kind of progress you would see in children who are maybe not having access to just a baseline or a base program. And we also know that children who come in with the fewest words, so if we see them at age 3 and they have fewer than 5 words, we know that those children benefit most from this training on joint attention. So it's really important to focus in on these skills for young children with autism. Okay. Let's see. So active ingredient then is focusing in on joint attention and play. We followed these same children up 5 years later, and they still were doing better than children who didn't have these interventions. 80% of the kids that we followed up became verbal and had normal intelligence. But when we saw them at 3, they were very, very, very delayed. They did not have normal intelligence. So again, early intervention matters. Let's see, I think these are, so I'll show you a little boy that we saw at age 3. Lights again. Okay, so what you should notice about him is he's asking questions, he's answering questions. He's very well connected with his eye contact and his smiling. So he had the joint attention early at age 3 and is doing great and had a 47 IQ, so that's very delayed at age 3, and has a 97 at age 8. So children make progress. And those scores early on are not very stable anyway. So it's great to get in there and give them a dose of intervention and see what you can accomplish. Okay, so delivering early interventions in an under-resourced settings where you don't have access to a whole army of professionals and children aren't in schools, what we need to do is to really think about how we're going to train a workforce. Parents and teachers, right? Parents have the child, teachers are in schools, and in the United States, children go to school from age 3 and older. So, it's a given that they're going to go to school. Right, so the reason that children go to school in the United States is because parents banded together and demanded it. It wouldn't have happened otherwise, and that was in the late 70s. So that made a difference. Autism became its own category for special education or for specialized education in 1990. So pretty late. But since 1990, there have been specialized autism programs for children on the spectrum. So I think we need to think about training a workforce, having enough professionals to go around to help parents and teachers actually make change. And we need to be creative in sort of providing that support. It might be hands-on, because we know that that's more effective than just giving information. But just giving information is really important too. Right? So that's a place to begin, is just giving information, which is what we're trying to do here at this conference. And then the next step is hands-on interventions. And we might need to think about using technology in helping families and teachers gain that sort of hands-on experience. We also know that one size doesn't fit all. If the child is not making progress in 3 months, you need to change something. You need to augment. You need to either increase the dose, you need to change something about the methods or the targets. So we know in the United States that 3 months is our window to test whether something is working or not. So I've done a study recently of 112 families that were very poor. So 66% of them were at the poverty line or below. Very diverse families. In the United States, we have unbelievable diversity. So ethnically, racially, culturally. And we did this Jasper treatment with them in the home twice a week. Or we compare, we do studies. So we compared it to just giving them the same information in a group setting. And what we found was the top line, which is giving them hands-on support matters. They're making a tiny bit of change with the just informational support, but we can't expect families to know what to do with their child if they just get information. So while I'm telling you, yes, do joint attention, you're going to have many very specific questions about how you do that, and very specific to your child, which is why you need professionals involved. Okay, we also know that when we work with teachers, even specialized teachers of autism, that again, the top line is teachers who got hands-on support in the classroom with children with autism. We can change the child outcome in engagement, in play, in joint attention. But the bottom line, the bottom line is teachers that just got the information at where the circle is. So at the end of treatment for the first group, we started to give information to the waitlist group. And they learned a little bit. They got a little bit better just with that information. So again, information is a place to start. Okay, let's move on. So we have written materials that we give out to teachers that helps them. We give this information in weekly doses, kind of building on the information. So again, information is important. And the next slide, let's see, is my ending, which is about right. Yes, I'm so good with time, aren't I? Even with technology glitches. So most of the intervention work in the U.S. has been one-to-one adult to child, and intense. That model is very expensive, but no one model has been effective over another model. So even if you give that, so some of our kids get 40 hours a week of one-on-one therapy in the home. Can you imagine? It's like a whole work week. And that model is actually not more effective than other models because we haven't ever tested that. It's better to know what those active ingredients are and to deliver those in a very targeted fashion. So even less dose is probably effective. And then some of our interventions really aren't very culturally compatible or family sensitive. So I would argue that having someone in your house for 40 hours a week doing one-on-one therapy might not really work with your family. So you have to think about that and what works and what doesn't work. So we need lots of other methods for delivering this information, including web-based models, iPad applications. I see a lot of people have iPads. We need to be able to figure out how to deliver that information to you. And we've been working on some of these models at UCLA. So we're hoping that in the future we can sort of disseminate some of this work. And then, of course, we need to build that workforce. Teachers, therapists, parents, everybody needs to be on the same team to really make a difference. Thank you.
На слайде, где было написано «Чему учить», у вас было отдельно выделено разделенное внимание и совместное внимание. Почему вы разделяете их?
That's a question about
Shared attention. Right, so both of those are impaired in kids with autism. Shared attention meaning I'm looking at you and I'm smiling and I'm connected. Right? So that's important, and that's a place to begin, because little babies do that first, and then they develop this shifting of attention. But shifting of attention is around sharing, again, sharing an event, sharing, another person or an object. And unfortunately, a lot of people only train attention, right? The kids, that can be aversive to children with autism, this one eye contact. And in fact, it's abnormal to look at somebody for long periods of time. I don't know if in Russia that's culturally weird. I think it's weird in the United States if a child is just looking at me. The only people who do that are people in love. And that only lasts a couple of weeks, right? So Unfortunately, yeah. So new loves, you're all into that. But after that, yeah. Does that make sense?
Спасибо. Вот был следующий вопрос здесь, потом вопрос здесь. Покажите. Спасибо.
Good question. So we do. We have a manual, and we have a manual for teachers, and we have a manual for parents, and a manual for therapists. The problem is you really need we need to show you. It's too easy to go down a very different path. And so the details, it takes a week to get the initial training and then practice. You come to me. I will train you. Bring me here and I'll train you.
Мы на этом не будем задерживаться.
Yeah. Yeah, so yes and yes. For children who are minimally verbal who are over age 5, I have 2 programs for them that I have funding for. And we are teaching them communication. I'll have some video tomorrow of that, where we use an iPad to help within the context of the therapy to get them to talk. And then with teachers, when we train teachers, they don't do one-on-one. And so they do small groups. And the goal is to get the children to play together. I have lots of video. I just don't have time to show you all of these different things. But we do teach teachers how to do 2 kids together. And then I have other programs that we're researching in the schools, public schools, children in inclusion who are high functioning. And we teach them how to engage with their peers, because it shifts from adult to peers in school. So I have all those programs going.
Спасибо. У вас был вопрос. Только пытайтесь.
Спасибо.
So IQ scores are based from standardized test scores, like the Stanford Binet, like the Bailey, like the Mullen, like the DOS. There are zillions. Cattell, wasn't that a Russian? Yes. Cattell? Old, right? Yeah. So those are standardized measures. When children are really young, like under 5 or 6 or 7, those are not very stable. They're only stable when the child tests very, very, very low. those scores are stable. But we see a lot of 2- and 3-year-olds who come in with a 50 IQ, half of of what's normal. 100 is your standard mean score, average score, and 15 is your standard deviation. 2 standard deviations below 100, so 70, is intellectual impairment. They're just cutoff scores. The problem is that the kinds of things that the activities we do with young children, they change rapidly in early childhood. So they're not very good measures of potential, really. Yet, we teach those things, and they do get better. They change over time. It's just not a core deficit. IQ is not a core deficit of autism. In fact, most people think that the children are not intellectually impaired at all, and that, in fact, we just need to help them develop, and their IQ will be normal. It's not always true, but yeah.
Спасибо. Спасибо.
Yeah, so children need a medical examination, certainly, for hearing impairment, for other kinds of medical issues that children can have in addition to autism. In terms of, and the diet is, as we said this morning, for some children, you know, they have an allergy to milk. That makes sense. The studies that have been done on diet, if you just have autism and you try the diet, that doesn't seem to make a difference. And they're very expensive and they're hard to stay up with. So make that decision carefully based on your child. But individual children need have different medical needs. In terms of development and learning, educational or behavioral interventions are the only thing we know that are effective at this point in time. So you need to do whatever it is you're doing in combination with that behavioral intervention. But I'm not saying behavioral interventions are the only thing any child ever needs.
И я возраст детей на входе, на выходе. Вот что такое программа раннего вмешательства в Соединенных Штатах?
So early intervention is, in my mind, getting to some problem early. You could be 16 and have been in a car accident. That's when you need to have early intervention, right? So, or you're 16 and you've developed anxiety. That's an associated problem. You want to get in there early, but you may not have seen it at age 3. So whenever the problem occurs, that's early.
Извините.
Первая помощь.
But the question is, what... Okay.
Talk to me.
Я, насколько понимаю, еще раз, если переформулировать вопрос, все-таки у вас же есть стандартные какие-то критерии, в каком возрасте это будет образовательная программа, а в каком программа раннего вмешательства, да? Разные будут системы оплаты, в том числе помощи детям, или нет?
So in the United States, we try to see children by age 2 to 3, whenever they're first diagnosed. But if you don't get into intervention until later, it doesn't mean that you're not going to make progress. It's best to get in there when the problems occur in the beginning. That's early. Yeah.